It's my privilege now to once again express our gratitude to a leading psychiatrist, practitioner in the field, whose sensitivity and guidance we've been fortunate to assimilate, Dr. Gary Kennedy, the Director of Psychiatry at Montefiore Medical Center.
Well, I want to thank the sponsors for having me return with you this evening, and I certainly want to echo the Rabbi's kind concerns about how our sense of caring for one another, and especially our sense of caring for our older adults, has been, I would argue, in the last years to some extent perverted. And we may have a chance to talk a bit more about that, and I can express that in some of the scientific terms as part of my background. But again, I want to appreciate the opportunity to speak with you and answer questions. Those of you who were with me last year and did not get burned out from my comments then and wanted to be punished some more and you came back, you'll recall that what I would like to do to discuss things with a group such as you is to speak into the microphones, but also to elicit some questions from you from the outset. That will give me an outline of what I want to say. And then after I've spoken and addressed 4 or 5 questions from you as an audience, then I'll open it up for some more questions. And this give and take, this back and forth, lets me know what your experience is like so that I learn something from you as family members, caregivers, persons in this community, but also gives me a chance to speak back and forth to you. So maybe I could just open it up with asking you, what questions do you have about dementia, Alzheimer's disease, healthy aging, memory, any of the above? Questions, please. Yes, ma'am, in the back. So the question is, how do we avoid forgetting? Well, how do we avoid forgetting? And maybe a subset of that question is, what is memory? How do we preserve it? And I'll try and address that as well. So that's a healthy aging question. Yes, ma'am. Is dementia genetic? That's a good question. We'll address that as well. Should the ill person know they're ill? Also a question. Good question. Yes, ma'am. I'll repeat the question.
How do we help the person when they are unpredictable? If you want to get somebody to help them, besides myself, if the person is unpredictable, you're going to call someone to your house. You can't just tell them, come in and go where the person wants to go or doesn't want to go, or wants to eat now or doesn't want to eat.
So the question is, how do you anticipate the needs of a person who's unpredictable? How do you cope with that? Could we have a question from the gentleman? Sir.
Does Alzheimer's necessarily go in a straight line down? Does it wax and wane? Can it go suddenly and then later stabilize? Or is there a trend that we follow?
What's the trajectory of Alzheimer's disease, or what's the trend? Now that's 5 or 6 questions. Let me try to address those. If I leave one out, you're going to remind me what I left out. And then we'll open it up for more questions. So the first question, which I would characterize as healthy aging question, is how do you support your memory? Well, you know the brain is something like a computer with hardware and software. Some of us have more education, so we're given a better software. Some of us are just genetically endowed with better hardware. But the brain is also a muscle. It needs exercise. And interestingly enough, there are hormones that are produced during exercise that support the growth of nerve cells. So physical activity is important to preserve brain activity. Now, memory is also a function of practice. You'll find some people who are, because they have dyslexia, because they've been blinded by some sort of illness later in their lives, so they really didn't learn to use Braille or other forms. What they do is to generate tremendous memories. Most of us don't have to rely on memory alone. We can write things down, we refer to notes, we can keep track of things that way. But it's possible to practice memory and increase it substantially. One of the key elements of that is what's called association. So if you can associate some component or element that you want to remember with something else, then you're more likely to encode that information stored in your memory and let it get into long-term memory. One of the techniques that's sometimes used, for instance, to memorize a grocery list is to think of all the things that you want to buy at the store, but then think of where you would put those things in your house. And practicing that way, you can put the bread goes by the sink, the salt goes in the cabinet, on, and putting things in position like that helps you structure and helps you remember those things. So yes, there are a lot of memory tools and memory tricks that you can use, but the whole point of memory is to keep using it. It turns out that up until age 90 and beyond, we actually can increase our vocabulary if you have practice and if you have exposure. So yes, you can learn a new language at 75 years of age. It's going to take you longer than if you were 15 years of age. So yes, memory will increase, but your access to memory and the speed with which you remember, inevitably that declines. So that's healthy aging, and one of the things I would want to emphasize tonight is that we're all told and we're all threatened about how we're not going to be able to afford seniors, not going to be able to afford their housing, their health care needs, their support. Part of the theme that you just heard is we've lost a sense of respect for elders. Part of that is a misreading of epidemiology. If you actually look at the most recent reports that look at older adults at very advanced age, it turns out that healthy aging is the new norm, that the vast majority of older adults, up until the last year or two of their life, are pretty independent. That doesn't mean they're terribly healthy. Yes, they'll have illnesses, yes, they'll need a little help, but by and large, they're pretty much autonomous and independent. And that trend has been increasing. We're not increasing the lifespan that much. Most of the gains in lifespan came about 50 and 100 years ago. But what is increasing is the active lifespan. So what we should expect is older adults today are going to be more independent than their parents ever were. And what that means is they're going to be contributors to society, they're going to be consumers, they're going to help one another. So the notion that we can't afford older adults is just scientifically invalid. That's scientifically wrong. Question about is dementia genetic? So let me give you two thoughts about this. First of all, dementia is an umbrella term. Dementia is an umbrella term. Dementia is to Alzheimer's disease the way cancer is to leukemia. So it incorporates a whole range of different illnesses. Alzheimer's disease is probably the most common, but there's traumatic brain injury that causes a dementia. Heart attacks and stroke, diabetes can cause dementia. There are infectious forms of dementia, HIV, AIDS can form a dementia. There are also rare forms of transmissible dementia. It used to be that there were organs that could be transplanted and weren't tested ahead of time for these transmissible dementia. Now they're all tested, so there's a new safety. There are genetic forms of dementia, and when I say a genetic form, what I'm talking about is a dementia that, like Huntington's disease, which is called autosomal dominant transmission, meaning that half the people in the family will develop the illness. Now, there's now a test for Huntington's disease that is 100% accurate. So we can tell people, yes, you're going to have the disease, you may carry the gene, but you're not going to develop it. We don't have tests for Alzheimer's disease that are that way. There are perhaps 100 families worldwide that have this autosomal dominant kind of transmission of dementia. That's called a familial dementia in Alzheimer's disease. It's rare. Now, there are studies underway presently to look at how the genetic products, how medications might modify that. But most of the genetic contribution to Alzheimer's disease is relatively small. You may have heard of a protein called apolipoprotein E or epsilon. There are 4 different forms of this protein. The 4th form of it, if both parents transmit that to you, your risk of dementia is elevated. But the problem is that estimate is so rough that it's really not worth testing people for that. You'll see this in the scientific studies that some segment of the sample that participated in the study was ApoE4 positive, and they may have had a different outcome. But the problem is I never send someone for that particular test because it's not informative. Just because you have that marker doesn't mean you're going to get dementia. Just because you're free of the marker, that also doesn't mean you're going to have the dementia. So I would argue that the genetic contribution is relatively small. Would also argue that presently there's nothing we can do about that, right? So if you have a first-degree relative, mother, father, aunt, brother, sister who has dementia, yes, your risk is elevated, but it's not substantial. It's maybe about the same as if you had a relative that developed diabetes. Yes, your risk of diabetes is elevated if you have a close relative with it, but that doesn't mean you're going to get the illness. The question about the trajectory of dementia, as I mentioned to you, Alzheimer's disease is the most common, probably the second most common form of dementia is what's called vascular dementia. This is the dementia that is associated with stroke, with heart attack, with heart rhythm disturbances, with high blood pressure, high blood sugar. The problem is both Alzheimer's disease and vascular dementia can co-occur. So you can have the Alzheimer's disease pathology, the process in the brain, along with the vascular changes in the brain that are associated with heart attack and stroke. Now, because heart attacks and strokes are relatively sudden, you'll see a person develop dementia relatively soon, and they have some decline, but then they may level off. That's characteristic of vascular dementia. And if you treat the vascular conditions, at least in theory, you minimize the risk of the progression of dementia. And there are some individuals who will develop a dementia-like syndrome as a result of vascular disease, and they'll be stable for a long time, may not further decline. So I'm always looking to optimize the treatment for any vascular condition the person might have. I'm also looking for that in the person with Alzheimer's disease. The trajectory of Alzheimer's disease is what's called a smooth decline. If you look more carefully at the scientific data, it's sinusoidal, meaning in the beginning of the illness, it's a relatively slow decline. In the middle, there's a more rapid decline. At the very end of the illness, there's less decline because there's less brain left to decline. And it's in the middle phase where you find the behavioral difficulties, which are why people come to psychiatrists for help when they have a relative with dementia. That gets us to the issue of unpredictability and how you cope with that. Well, I think as the rabbi was telling us in the opening comments, the environment needs to be safe, warm, and welcoming. It needs to be tailored to the needs of the person with dementia. Now, for some individuals, that means a lot of stimulation. They need a lot of orientation, activity. They need to be busy. They need to have something to do. They need to be oriented. For other individuals, it means they need less stimulation. In a sense, they need to be left alone and at peace. So as you heard earlier, the family needs to adjust to that expectation. And are there going to be unpredictable moments? Well, absolutely. If they are recurrent, oftentimes a sudden change in the person's mental status, they become combative, or they're sleeping all the time, appetite is lost, that may be because there's an infection, bladder infection, a cold, lung infection. So a sudden change in the person's mental status, I always send the person back to their internist to make sure there's not an infection that's causing the problem. The other issue about caregivers is that some people are just natural at it. It turns out males are not necessarily the best caregivers. There are some males who are absolutely wonderful, but women typically are socialized into the caregiver role. And what you'll find is that it takes the right match between the person who needs the care and the person who's going to provide it. There are some people that I work with, and no matter what I say, it's just difficult for them to adapt to that role. So part of the answer to how do you cope with the unpredictability is it's a trial and error process. And not everyone that you might have come in is going to be good for that. So I always say, yes, you need some help. You need a companion to come in and be with the person so you have some respite time. But remember, the first person you have in, it may not work. So there's an issue of chemistry. And on occasion, you find someone who was very difficult for the family, no matter even a loving family who was bending over backwards to be careful and do exactly the right thing, the person still has conflict. But you bring another person in, something about the chemistry of their match takes away some of the conflict with the family. So it's trial and error, and you shouldn't expect to get it right the first time, and you certainly shouldn't expect to get it right every time. And I think yes, please.
Was suggested to take speech therapy. You can talk and you can't write. But it worked a little bit, but he doesn't want to go. What are you going to do? And the speech therapist was very nice, very good person, caring. In the neighborhood, the person doesn't want to go.
Right, so the question, to repeat the example, here's a person who has communication problems. The speech therapy is available, but the person doesn't want to go for speech therapy. It could be the same example as my exercise prescription. When I say exercise prescription, I'm always saying you need to get out and have a walk 30 minutes a day. You don't have to run, no calisthenics, no weights, but get out for a walk. It's good for your heart, it's good for your brain. That's the most difficult prescription I write because it means changing behavior. Taking a pill easy, changing behavior difficult. So again, it becomes what one would call a risk-benefit burden analysis. Yes, more aggressive intervention such as speech therapy, such as exercise, such as that walk every morning, getting out of the house. Yes, that's going to be good for the person, but is it going to be upsetting and irritating? Or is it going to be so much work for the caregiver that it's counterproductive? The caregiver ends up upset and angry. So there has to be this balance. I like to argue that there's no exact way to do this as being a caregiver. You have to adapt, and you have to be reasonable with yourself, as well as reasonable with what you can expect from the older person who has dementia. Yes, ma'am. Yes, please.
You mentioned that some people need more stimulation and get busy and stimulated, but some people need to have quiet time. Now, are you talking about the same person, sometimes this way, sometimes this way? That's one question. Also, are you talking, how can we tell what type of a person our loved one is? Needs more stimulation or needs quiet?
The question is about stimulation, how you get the right balance. I think you have to observe that, and again, it's trial and error, trying different things out. The question about, well, sometimes the person needs to be low stimulation, other times they need to be high stimulation. I think that's the case for some individuals. The point I'm trying to make is not to think the person has to have more stimulation or be left alone, but get it right for that individual. And again, that's a trial and error process. Some people just intuitively know what to do, how much to provide. Other times it's going to take time and effort to make that decision. The question is one of insight. Should the person who has the dementia, to what extent should they be aware of it? First of all, it's a myth to say that persons with Alzheimer's disease are not aware of their deficits. There are some that deny it, some that just won't accept the help. No matter how you say it, how nice you are about it, they're not going to hear that. And if I use the word dementia or Alzheimer's disease or loss of independence, I've lost the patient. So I know to manage my language in a way that I can tailor it to their needs. The patients that come in, their families, they have something they want me to do. And yes, diagnosis is part of that, but more often than not, they want treatment and they want to know what to expect. I don't have to use the dementia word or Alzheimer's to tell them what to expect and to try to help them make a plan. And I don't have to have the end plan in mind right then. This should be a process, a stepwise process. So the way I would answer your question is how much does the person need to know to maintain their independence and autonomy and their dignity? Does the person have to confess to having dementia? Do they have to acknowledge that and say it? No. My concern is, are they going to be able to participate and cooperate and benefit from whatever treatment plan we put in? And do they have sufficient understanding of that to benefit from it? Now, if the patient asks me, Doc, what is this? I'm not going to lie to that person. I'm not going to use baby talk language. I'll say, I think it's a dementia. I think it probably is Alzheimer's disease. But when I say that, I'm always careful to say, we're going to work on this. Can't cure it, But yes, we can treat it, and I'm going to work with you. I think what families and patients fear the most is that when they get bad news like cancer, like stroke, like dementia, that the physician is somehow washing his or her hands of them. I think countering the fears of abandonment is maybe the most important part of the information of bringing bad news. And again, it needs to be tailored to how much the person wants to know. So if the person says, well, okay, what's the medication? I'll go right to the medication. I don't have to review all the components of the diagnosis. Yes, there are issues about advance directives. What do they want at the end of their life? What should the family expect? What other things can I recommend? But that doesn't have to be done all in one visit. So build a relationship, learn the person's style, how they interact, how much information they want. Sir? How is dementia diagnosed? It's still a clinical diagnosis, by which I mean through a clinical interview and history. It's not like diabetes. It's not like a cardiac rhythm disturbance, where we have a blood sugar level that we can say at this particular blood sugar level, hemoglobin A1C it's called, you have diabetes or you do not. We don't have that for dementia. So what the diagnosis entails is, by definition, there should be progressive decline. So the person's capacity to function socially, how they would define socially, whether they were a homemaker, whether they were a leader in business or university professor, there's some decline in that previous level of function that's troublesome, that's interfering. It's not just a little fluctuation, but it's something substantial, and it's persistent. So that's the first element. Second element is there should be some measurable cognitive deficit. Now, the former diagnostic pattern for dementia from the Diagnostic Statistical Manual 4 mandated that dementia had to have a memory deficit to be diagnosed. We now think that for Alzheimer's disease, memory deficit is critical as to the diagnosis. But as I said, critical elements of dementia are one form of cognitive impairment that's measurable, plus the decline in social function. Now, that cognitive impairment, yes, it could be memory. And when I say memory, actually, from my perspective, I'm talking about learning. For instance, I'll test the person's memory by giving them a list of words and categorical cues so they can learn the new list. And that's actually learning. The memory for years past, for names of loved ones, for their address, that's consolidated memory. That stays a long time. That's some of the last memories to go in the disease process. Newly learned information, that's the memory problem of seeking. But I'll also look, and the person could be free of memory impairment, but let's say they have what's called executive dysfunction. Now, executive dysfunction is difficulty planning, difficulty executing a task, difficulty staying focused on the right task, keeping external distractors out of your awareness, being able to switch tasks. That's called executive dysfunction. You remembered, and I remembered, that there was a meeting tonight, but we had to use executive function to find out how to get here, especially me coming from the Bronx. I had to solve the maze, and then when I arrived, I had to solve the parking challenge. And that was a lot of executive function for me tonight. But there are also maybe three other elements. There's communication deficit called aphasia, meaning the person doesn't understand what's being asked, or the person can't express their needs adequately. There could be social decline that's progressive, and the person could have aphasia. That's sometimes called primary progressive aphasia. There could be apraxia, which is difficulty manipulating objects in space. Can't brush your teeth, and you can't explain why. That might be apraxia. And then there can be what's called anomia. Anomia is difficulty naming things, and that could also be difficulty recognizing family members. So any of those 5 cognitive elements, which are measurable, and there are measures that are normed for age and education, so we know when the person's failing, plus the progressive decline, that would be how it would be diagnosed. Now, of course, critical to that diagnosis is making sure there's not some other reason for the problem. Does the person have undiagnosed diabetes, and the reason their attention is fluctuating is because their blood sugar is fluctuating? Do they have a heart rhythm disturbance, and when their rhythm is out of whack, their cognition is impaired? Do they have a sleep problem that that is such that in the middle of the night they're not oxygenating properly, their blood oxygen is going down? Do they have a thyroid hormone problem that's not been addressed? All those things need to be looked at. Most often, though, when there's slow progressive decline, it's not reversible. The studies that have looked at for a reversible cause of dementia, and of course every patient I see who I think has dementia, I'm making sure their internist has run this drill. Most often you're not going to find that reversible, that other reversible illness. Nonetheless, it's critical that those other illnesses be optimized. Treatment has to be best. The hypertensive treatment should be exactly right, not too much, not too little, the same with the anti-diabetic treatment. Yes? The question again is about communication and speech due to Alzheimer's disease. And because Alzheimer's disease affects the surface of the brain, which is where our speech programs are located, oftentimes it impairs it. You can't stop that process, but I would argue a family member can cope with it in a particular way. So for Alzheimer's disease, oftentimes the same with a patient who has stroke and aphasia, is they'll stick on a word, or they'll miss something, or you'll see them stutter, and you know they're trying to find that word. It's not like a child where you say, you know the word, keep trying. You should fill in the blank. And filling in the blank helps the person maintain their cognitive momentum. And that kind of approach is probably the best way to try and counter the communication deficits. Sir? Right. The question is about medications, and let me give you my perspective on that because it's very, very important. There are some families and there are some patients whose bias about treatment is to avoid adverse events. So they would say, first, do no harm. Other people want to maximize the potential of benefit. So they're less concerned about avoiding harm, and they're more concerned about the benefit. Now, we don't have any medications that are without risk. We do have medications that are not necessarily beneficial. So I try and gauge from the person, do they want me to work with them in purely behavioral fashion, with counseling, talking with the family, working with them in that fashion, or do they also want medication? And then if they want medication, do they want me to minimize the risk associated with the medicine, or they want me to maximize the potential benefit? If we want to minimize the risk, then I'm going to use a medication like memantine or Namenda, which is easy to tolerate, takes twice a day, you build it up over a month. Rare that a person has a side effect. Maybe 40% of people will have some benefit that the family will notice. Another 20 or 30% of people will have some benefit, but it's not going to be obvious. So after 6 months, if I'll ask the family, do you think the medicine helped at all? If they say no, then I'm probably going to say, well, let's just stop this medication. That would be a very conservative approach, risk-averse approach, or no medications at all. If they were to say, well, let's have a more aggressive approach, what else have you got? Then I might use what's called a cholinesterase inhibitor. This is donepezil, galantamine, rivastigmine. Aricept is probably the one that's most commonly used. And I'll start that at a low dose. I'll double that dose. If the family wants more aggressive effects, we can double that dose again. But as you double the dose, you encounter much more risk of side effects. And while memantine or Namenda is relatively free of side effects, the cholinesterase inhibitors as a family, a little bit more difficult to tolerate. They're pretty safe. They're not going to stop your heart or make you faint or cause a stroke or ruin your blood sugar, but they're a little bit more difficult to tolerate. Now, would I combine Namenda with a cholinesterase inhibitor? Yes. If the family said the first cholinesterase inhibitor didn't seem to be beneficial at all, I would taper that away. If they saw no change when we tapered it, then I might try a different cholinesterase inhibitor, and again, I would push the dose up. If the person were apathetic, didn't want to do anything, tended to sleep too much, both night and day, I might try a stimulant like methylphenidate or Ritalin, again, with the family's perspective, and of course with the patient's permission about this. So there are a variety of medications we have that are available to help memory. They don't technically slow the decline. They push the decline back maybe 6 months. And I think patients are better with these medications than without. But this is Tylenol for arthritis, right? It's not insulin for diabetes. So yes, they're beneficial, but they're not dramatically beneficial, with the rare person, maybe 1 in 10, where within the first week or so of treatment, the family says, yes, we really notice the benefit. So I look for the family and the patient to give me some direction about how aggressive or passive to be about medication. I'm sorry? The question is, how do I know the person's going to take the medication? Well, of course I don't, but I do expect that with the help of family, there's going to be some surveillance. Most of the older adults I treat, rare exception, they have 2 or 3 conditions. So they're getting several medications, 2 or 3 medications. I almost always am recommending they have a pill organizer that could be Monday through Sunday with AM, PM, or even 3 or 4 different containers. And filling those up means that family can check and see if any doses have been missed. So you're right, if the patient's not taking the medication, or they're going to take it sporadically every other day, then I would say you're getting exposed to the risk, and you're not getting exposed to any benefit. So if the situation is such the person can't reliably take the medications, there's not sufficient supervision, I would rather not prescribe. That doesn't mean they can't come see me. I'm happy to follow, and of course this is a progressive illness, and I do work with patients from diagnosis to death, so my commitment for the person is to work with them throughout the course of the illness, but not, if they don't want the medications or they can't manage it, then so be it. Yes, ma'am. Okay, the question is, the medications, whether singly in combination, are only good for a year. I don't think that's correct. The original studies were either 6 months long or a year in duration. So some people have interpreted that to say, well, the medications only work for 6 months. And if you look at the score on a measure of cognitive performance related to the medication, the person, after they've been on the medication 6 months, typically their score is back to where it was at baseline. Now, have they lost ground? Yes, but they would have lost more ground without the medication. So I will typically advise, if you think the medication was beneficial, let's stick with it. If you didn't see any benefit whatsoever, let's taper it off. And in the process of a few weeks of tapering it off, if you see a problem, then we go back to the medication. The time I suggest taking the medications away is when the person no longer recognizes family. Once they can't interact effectively, I don't see the point of the medication, because these medications are to assist with behavior. And if you look in the nursing home and you look at ask family, they don't say, well, he remembers how to dress himself now. What they say is he seems a little more alert, seems to interact with us a little bit more. And I think that's more important than activities of daily living. It's this interpersonal component, as the rabbi was saying, that I'm most interested in. Yes, ma'am.
What would you suggest the onset? How high would you go up? What would be the maximum?
So the question is, what's the maximum for Aricept?
And for Namenda?
The typical dose for Aricept is 5 milligrams once a day. Should be given in the morning because it alerts you. It's not a bedtime medication. Almost everyone I'll say, let's go on up to 10 milligrams if they tolerated the first 5 milligrams well enough. This is Aricept. The question is Aricept. So I'll start with 5 and I'll increase it to 10. There is a 23 milligram form of Aricept that's approved by FDA that can be prescribed. It doubles the risk of a side effect. Side effect from Aricept is nausea, vomiting, gastrointestinal predominantly. 1 person in 1,000 will have a fainting episode. If that's the case, then I stop the medication because it's changed their heart rhythm. But it's rare that I'll warn the person because that's unusual. So again, it depends on how much risk the person wants to take and how aggressive they want me to be. If they want aggressive treatment, then we can increase the Aricept from 5 to 10 to 15 to 20. And yes, I would combine that with Namenda. I don't increase the dose of Namenda beyond 20 milligrams a day because sometimes it can cause confusion at higher doses. Yes, Aricept's a morning medication. Of Namenda? 28? I haven't heard that. Haven't heard. Okay. I'd love to see it. Yes, ma'am.
Once cognitive impairment sets in, do games like Lumosity, can they help at all, or is it just frustrating?
The question is, what about the computer games? And there's a lot of, right, luminosity, other things. There's a lot of information out there on the web and otherwise. It turns out that people's performance on the computer games, seniors, do better with training, and that training they have has a lasting effect. So the computer games do have an impact on the brain. You can increase your memory, you can actually increase some of your reaction time and being able to handle more things. So yes, the computer games and the mental practice has its effect. Does it have an impact socially on activities of daily living? That's not clear. So the studies we'd like to see that this particular form of cognitive manipulation slows the decline of Alzheimer's disease, I'm not aware of any studies that have demonstrated that. So I would say, yes, the brain needs a good workout, but it should be something a person really enjoys doing, right? And if luminosity does it, fine. If crossword, simple crossword, if drawing does it, if conversation does it, if singing does it, that's fine. So I wouldn't burden the person with, here's what you have to do to maintain. I think I should take one last question because I'm afraid I'm taking too much of my time. Yes, sir.
Is Alzheimer's a positive diagnosis? I mean to say, do the doctors sometimes just take the easy way out, or do they, you have to basically is it basically diagnosed by eliminating everything else?
That's a good question. What's the certainty of the diagnosis, and do physicians are physicians wrong about it? It turns out, as I mentioned, it's a clinical diagnosis. We don't have a laboratory test for it. But if you have sufficient history and if you follow the person for a year or so, more than 90% of the time you're going to be right that that the diagnosis is dementia. Now, if the person has an autopsy and the pathologist looks at the brain, it may or may not be Alzheimer's disease. Alzheimer's disease probably is because it's more frequent. But the diagnosis of dementia is pretty accurate under those circumstances. Did that answer your question? One more.
If you don't take it every day, if the patient needs down a day or two, is it going to work? Is it not going to work?
No, none of the dementia medications work when they're taken sporadically. And again, as I mentioned, I think when you take it on and off, all you're getting is the risk, none of the benefit. So I know there are other questions, but I'm afraid I'm taking up too much of your time. So it's always a pleasure to speak with you. I appreciate the questions, and I learned a lot asking with you. Thank you so much.
of the New York City chapter. In addition to that, Matt also oversees a 24-hour helpline. He's the Care Consultation, Education, and Training Programs Consultant, and is also responsible for the early stage services and support group programs for the American Alzheimer's Association. In Matt's spare time, he's also an avid tennis player, and he comes to lecture here once in a while, but it's really a great honor to have him here tonight. I just want to make two program notes. First of all, a special thank you to Mrs. Horowitz, who really put this program together. I appreciate it. I also want to thank Matt and the American Alzheimer's Association for their caregiver support training programs they provided for our community, run by Lauren Volkmer, who are very, very popular programs. And if anybody wants to reach Dr. Kennedy or get into one of these special programs, whether it's the support group programs or the caregiver training programs, please contact Mrs. Horowitz and she will set it up for you. Without further ado, Matt Kudish. Here we go.
Good evening. Thank you so much for having me back this year. It's really my pleasure to be here. Following Dr. Kennedy is no easy task. I'm just stalling for a couple of minutes while we set up the PowerPoint presentation. I'm actually grateful that Dr. Kennedy spoke before me because he covered a number of the things that I had planned to talk about in my slides. So we'll be able to skip over some of that beginning foundational information and really dive in more deeply into the enhancing communication and managing challenging behaviors piece. My sense from talking with Leah is that people are really hungry for concrete tips and tools that can be used to work more closely and more effectively and engage more meaningfully with the person with dementia for whom we are caring. And so I think that we'll be able to spend a fair amount of time talking very deeply about some concrete aspects to providing quality care. I think that a large part of what we're talking about today really has to do with developing relationship with the person for whom you are caring, really developing a meaningful engagement with the individual. And that truly starts with knowing who this individual is well before the disease was ever present. And I think we'll spend a little bit of time talking more in depth about precisely what I mean. So I will go over a couple of these. I think that in many cases, some of this more foundational information does bear repeating. I think that we can't ever forget that we are caring for someone for whom we care deeply. And it's very easy to look for concrete answers, but it's impossible to remove the emotional impact that comes along with providing care for somebody we really care deeply for. And so all of the concrete tools that I could provide for you would mean nothing if we ignored the devastation that happens to the relationship when we're caring for somebody that we really care about. So I think that's an important component of this today as well. And in order to reconcile the complicated feelings that so often go along with providing care to somebody with dementia, it bears repeating in many cases this foundational knowledge. So what is dementia? What are we talking about? Dementia, as Dr. Kennedy so eloquently shared, is actually not in and of itself a disease. Dementia talks about a state of mind where one is experiencing changes in memory, in thinking, in behavior, and in physical functioning. And there are roughly 100 different causes of this state of mind. Alzheimer's disease is one cause of dementia, and I liked when Dr. Kennedy said that dementia is to Alzheimer's disease as cancer is to leukemia, right? It's this umbrella term. There's the umbrella. Underneath this umbrella lies roughly 100 different causes of dementia, causes of that state of mind where memory and thinking and behavior and physical functioning become impaired. Alzheimer's disease specifically is a progressive degenerative disease of the brain that causes those same areas to be impacted. So again, memory, thinking, behavior, and physical functioning. This is just one specific cause. There are 99 or so other causes of this state of mind. We know Alzheimer's is the most common cause of dementia, and it is a fatal disease. I should have started off by saying that some of what we're talking about tonight, if not all of what we're talking about tonight, is not easy to discuss. It's not easy to talk about. I'm often the bearer of bad news. I have accepted that about my job. I think that if I were to come up here and sugarcoat things or wrap things in nice cotton batting and try to couch things in a way that wasn't really factual and realistic, that I wouldn't be doing my job. Clearly, you're here because you are looking for information. And so I want to acknowledge the fact that some of what we're talking about is incredibly difficult to discuss. It's hard to wrap our heads around, especially when we realize the emotional impact of caring for somebody we care deeply for. And so I think that that's just worth saying. We know that today over 5 million Americans are living with Alzheimer's disease. It's the 6th leading cause of death. It's the 6th leading cause of death across all ages, not just among older adults. In less than 40 years, by the year 2050, that 5 million Americans that I mentioned will jump to anywhere between 11 and 16 million Americans living with Alzheimer's disease. Why, did someone say? Why? The population is aging. So as baby boomers are aging, becoming 65 and over at greater numbers than we've ever seen before in this country, we do know that the greatest risk for developing dementia is getting older. And so as the population ages, we're seeing more and more people becoming susceptible to dementia. Can it be environmental? You know, I'm going to get to a lot of that, and I did bake in some time for questions, so I want you to ask that again at the end if you feel I haven't touched it enough. But I prepared a lot of material that I want to make sure that we get to, and I think if I opened it to questions now, I probably wouldn't move one more slide. So I'm going to ask for your patience and trust in me that we will move forward. So by 2050, instead of every 68 seconds someone in this country being diagnosed, we're looking at roughly every 33 seconds. And what that means for us here in New York City, is that 1 out of every 5 New Yorkers will either have Alzheimer's disease or be caring for someone who does. And I share this information really to give a context to what we're talking about, to help everyone understand that this is the most significant health crisis of this century, that we're dealing with a tsunami, if you will, of a medical emergency that clearly is rippling throughout many communities in New York. The cost of care will exceed $1 trillion by 2050, which is no small amount of money. I'm going to skip over some of these slides now. As I mentioned, I'm going to go over some of these symptoms by the stage of Alzheimer's disease. I mentioned that Alzheimer's is a progressive degenerative disease. It starts in one area of the brain, which is called the hippocampus, and our brains are very compartmentalized. And by that I mean that very specific areas of the brain are responsible for very specific functions. So Dr. Kennedy mentioned that memory loss, short-term memory impairment, is an indication that the person may be experiencing Alzheimer's disease. It may not be related to other forms of dementia, but it is a true symptom of Alzheimer's disease. This is because the hallmarks of the disease, the plaques and the tangles that we believe are the result of or the cause of Alzheimer's disease, begin in the part of the brain that's responsible for our short-term memory. From that part of the brain, the disease spreads to the other areas of the brain. The path that it takes from what part of the brain it moves to the next part of the brain, and the speed with which it moves through all the other areas of the brain, that's what gives us the stages of the disease. So the path that the disease takes and how quickly it moves through the brain is what helps us understand where someone is in the spectrum of the stages of Alzheimer's disease. So if only small areas of the brain are affected by the disease, you're only going to see changes in certain areas, relatively small areas, right? As the disease process moves to other areas of the brain, more and more areas of the brain will become impacted by the disease. The person will be able to do less and less on their own, will become more and more reliant on others for different aspects of care. That means they have moved from the early stage of the disease, perhaps to the middle stage of the disease. As even more areas of the brain become affected by the disease, the person is almost entirely reliant on others for all aspects of care. They have moved from the middle stage of the disease perhaps to the later stage of the disease. Now you can get into much more deeper drill of the stages of the disease. Medical community often talks about 7 stages of Alzheimer's disease. I talk and we talk at the Alzheimer's Association in early, middle, and late. But within early, middle, and late lie those 7 stages. For our purposes tonight, I think that this is sufficient. We generally start with mild cognitive impairment, which is often a precursor to Alzheimer's disease, but in many cases it's not. We talk about normal aging changes in the brain, right? Dr. Kennedy spoke about that, where the brain, like the rest of our bodies, begins to change as we get older. Perhaps we don't remember the name of the movie that we saw over the weekend with that guy who was in that other movie that we liked. Or we can't remember, what we came into the kitchen for, or we don't remember exactly where our keys are. That kind of changes those kinds of changes in our memories, that's normal. That happens as we get older. When we're talking, I see some people breathing a little more easily when I say that. That's normal changing as we get older. That happens, right? I'm 39, that happens to me. I walk down the street on my cell phone and often have a momentary panic of, where's my phone? It's in my hand, right? That's not dementia. As Dr. Kennedy said, these types of changes aren't getting in the way of my ability to function independently, right? We knew that there was a meeting tonight. We knew how to get here. We knew what time it started. We were able to plan accordingly. Mild cognitive impairment means more severe changes in memory than the normal, healthy, older adult, but not so severe that it's getting in the way of our ability to function independently on a daily basis. It's kind of this middle ground where we maybe need a little bit more support from our friends and our families, but it's not so severe that it's getting in the way of our ability to function in a meaningful way. In some cases, people who are diagnosed with mild cognitive impairment do progress to Alzheimer's disease. In other cases, they do not. Unfortunately, we don't know until we know. So there's no way to really ascertain who will move forward and progress to Alzheimer's disease and who will not. For those who do, the next step in the progression is what we call early stage. These are the more common symptoms of early stage: forgetting material that's just read, losing or misplacing objects. And again, this is not where are my keys, because if I go home and I don't know where my keys are, I don't have Alzheimer's or dementia. I'm going to be able to backtrack. So I'm going to be able to say, okay, I came in and I had the groceries in one hand and my briefcase in the other. I had my keys in my mouth and I walked to the kitchen because I wanted to put the ice cream in the freezer before it melted. Okay, here are my keys on the counter or in the freezer maybe with the ice cream, right? Somebody with Alzheimer's disease, with that short-term memory impairment, they're not going to be able to as successfully backtrack. So we're going to see difficulty in their ability to find what they've lost. And in some cases, what this translates to is hiding things because it's important to them, and they don't want to forget where they put it. So I have this very important item in my hand. I don't want anything to happen to it. I'm going to put it in this very safe place, and then I don't remember that I did it because I'm suffering from early stage Alzheimer's, short-term memory loss. And now I think, well, I don't know where that item is, but you do, and you probably took it, right? I see nodding, so that's something that we're experiencing, right? This is very common. This is very common in the early stage. People are not doing it to drive us crazy. They're not doing it to manipulate us or get us to lose our cool or to act or react in a certain way. That kind of manipulation takes a high level of executive functioning, and Dr. Kennedy spoke very clearly about executive functioning, right? So we all knew how to get here tonight because of that. People with early stage Alzheimer's, while I agree with him that they do understand that something is going on, whether or not they admit it is a whole other evening, right? But they understand that they're experiencing changes. It's very, very different from understanding how they're reacting to things from the perspective of memory. By the middle stage, so the key from our perspective, and Dr. Kennedy did a fabulous job, I think, coming from the medical and some of the biopsychosocial, which means non-medical, aspects of working with people with Alzheimer's and dementia. I'm a social worker. I'm not a doctor at all. So I'm really going to spend much of my time with you this evening talking about the non-medical aspects of engaging with people with Alzheimer's disease. So for us in the early stage, the key is fostering independence. We want people to be doing as much as they can for themselves as they possibly can. We want them to be active and engaged in meaningful activities so that they're stimulated and they're participating in life in a meaningful way. We don't want to take away tasks from people while they're still able to do it. And I know that one of the things that Leah talked to me about that's a real struggle for all of us, not just the people here in this room, is figuring out how do we know where somebody is? When is it safe for them to still be doing things? When do we need to take over tasks? And I think that if there's a common thread to all that I'm talking to you about tonight, it's really that we have to start to become detectives. If you've met one person with Alzheimer's, and actually if you've met one person with dementia, you've met one person with dementia. And what I mean by that is we're talking about diseases of the brain. And each of our brains is unique, right? So that if dementia were to affect all of our brains, it would manifest in different ways. So that no two people with dementia experience the changes and the disease in the same way. So what might work for you may not work for someone else. And what might work for you today may not work for you in an hour. It may work again in 3 hours. It may not work again tomorrow. It may work again the day after. So trying to figure it out and trying to really put it in a box and make sense of it in a way that enables us to feel as if we have control over this is incredibly challenging. And I think so often, because of the nature of these types of diseases, we so desperately long for control because we have essentially lost control in so many ways, right? And I think that we would be on a fool's errand to think that we can figure out a way to grab this disease and control it. We have to understand that this is bigger than us. It doesn't mean we give up. And it doesn't mean that we quit trying. And it doesn't mean we just say, well, that's it, and we lose all hope. That's not at all what I'm saying. We need to remain as hopeful as we can, but we need to keep our feet on the ground. And that's to say that the interventions that we try need to be rooted in reality, but also with this strong sense of hope. And when I say we need to be detectives, what I mean is we need to dig deeper than what the person's doing and figure out why they're doing what they're doing. We need to think about who this individual was before this disease was ever present. And when we know who they were, we need to remember that at their core, that essence of who they were is never gone. This disease robs people of a lot of things. It does not rob them of who they are at their core. And when we as caregivers are able to understand who this individual is, who this individual was, we have a tremendous number of tools in our toolboxes so that as they begin to change and as things that used to work no longer work, we have myriad options from which to pull so that we can try a new way. So that when the old ways stop working, we don't go and bang our head against the wall. We remember what Matt said and we say, okay, that's not working right now. Let me figure out something else that might. So the key in the early stage, getting back to that, is fostering independence, allowing the individual to do as much as they can for as long as they can. The problem is we don't know when someone will move from early stage to middle stage. It's much more fluid than it is finite. It would be a lot easier, believe me, I know, if I could say, well, today my grandfather is in the early stage of the disease, but a week from tomorrow he'll be in the middle stage. So let me get all my ducks in a row and figure out everything that I need to do in the middle stage to be able to provide him with the kind of care that he needs then. It isn't that easy. It's much more common for someone to have 1 foot in early stage and 1 foot in middle stage. The decline associated with Alzheimer's disease is not this downward slope. It's more like a roller coaster. And my sense is if you've been caring for somebody with Alzheimer's disease, it probably feels a lot like a roller coaster for you as well, right? That's what it is. That's the reality of this situation. So when we're on a roller coaster, what do? We hang on, right? That's a good way for us to approach caring for people with the disease. We got to take these hills as they come. Take these slopes, these valleys, right? These ups and these downs as they come, and realize that there is no magic bullet. There is no one way that's right that's going to make this better. When we realize that, and we give up the idea of being the perfect caregiver, we allow ourselves to be human. We're human beings, right? Caring for someone we love, often, right? Not always. But caring for someone we care for. I mentioned earlier, all the concrete tools and tips in the world cannot remove the fact that we are doing this for somebody we care about, that we are experiencing an incredibly powerful emotional loss. We cannot isolate the way that we care. These are two facts that have to come together. So we need to figure out how to go with the flow. By the time the person moves to the middle stage of the disease, safety is paramount. I'm not going to go through each of those common symptoms. You can read them on the slides while I talk about what I mean by safety is paramount. In the middle stage, the deficits are more profound. The disease has moved from those isolated areas of the brain to more areas of the brain. So we're going to see the person needing more and more assistance, more and more problems with short-term memory, more difficulty processing information, forget reason, forget judgment, stop arguing with people with dementia, stop using reason and logic with people with dementia. All the old ways that we have historically communicated with this person are essentially out the window. That's the true hard fact of this disease. When we keep coming at the person as if they are the person they were before the disease was present, all we get is this, right? Raise your hand if you've ever won an argument with somebody with Alzheimer's disease. It doesn't happen, right? So my first tip, maybe not my first, one tip, stop arguing. You know what? One of the most powerful ways to reduce that level of engagement, I'm sorry. It just diffuses the situation. And even if you're not, you can be sorry. You can be sorry for a lot of things, maybe not what's happening right here, but that I'm sorry doesn't necessarily have to equate to that moment, right? So we can be getting into it, and I can say I'm sorry, and mean I'm sorry that this is happening, which is that's not a lie, right? That's the absolute truth. I'm sorry this is happening, but I'm sorry is going to diffuse that argument. Because if we keep trying to go toe-to-toe with somebody who no longer has the ability to process reason and logic, there's no point. You will not win. So understanding that their abilities are progressively declining, and the middle stage, why safety is so important is because this is when folks often put a pot of water to boil on the stove and leave the room because they forget. This is often when they run a bath and they leave the room and forget. Wandering is a symptom of the middle stage of Alzheimer's disease. We know that the vast majority of people with dementia will wander at some point. We don't know who and we don't know when. All it takes is a left turn instead of a right turn. The person's disoriented, unable to find their way back. Safety is paramount in the middle stage of the disease. By the time we talk about the late stage of the disease, and again, the symptoms are listed on the slides, which I'm happy to make available to Zicharon. We can get them to you if you'd like. I know this is being filmed. That's available for you as well. The late stage of the disease, comfort is key. People are no longer able to communicate in meaningful ways. In the late stage, most often all language is lost. We need to make sure that people are comfortable. We need to be providing care from what's called a palliative perspective. Palliative care means comfort care. Oftentimes, because people can't ask for certain things, they stop getting them. We see this very often with pain medication. People are experiencing pain, but because they no longer can say, that hurts, this hurts, I hurt, we stop treating them as if they're hurting. We need to begin to anticipate what people are going through, what people may be experiencing, and anticipating the treatment before things become so out of control that we're dealing with much more dangerous and serious situations. So some of the reflections on caregiving, and I tend to be a little bit loquacious, so I jump ahead of myself a lot and I go off on these tangents. Hopefully it all kind of comes back home to what we're talking about. Concrete tools versus the emotional impact. What I mean by that is what I've said several times already, that we cannot remove the emotional impact of caring for somebody with this disease by focusing on, Matt, give me the concrete tips and tools to make it better and make it easier. We have to always remember that there are two parts to what we're going through. And we can't pretend for a moment that we're not caring for somebody we care deeply for, right? None of us is born with the skills to care for people with this disease. This is not ingrained in us. Dr. Kennedy mentioned that women tend to be more of the caregivers, and they may be perhaps genetically predisposed with some of the skills more innately, right? Women's intuition, I believe, is a very real thing. I'm also standing on the women's side. I'm not going to say that's not true. But if you look at the numbers in the room tonight, right? I would venture to say roughly 75% of the crowd, women, maybe 25% or so men. Those numbers are typical across the country, across the world of caregivers. The majority of caregivers tend to be women. That said, none of us is born knowing how to provide the kind of care that we're talking about tonight. And what I'm talking about really at the heart of it is person-centered care. Knowing the individual you're caring for is person-centered care, because what it means is I'm going to develop interventions, ways to engage with this person that are unique to this individual who's right here in front of me. This is a very different way of caring for people than you might see with other types of diseases. With other diseases, and I think in many cases with a large part of our healthcare system, it's been designed as an if-then model of care. So if this is what's happening, then this is what we do. And if this is what we're seeing, then this is how we deal with it. With dementia, your situation is unique to you. And if you're in the situation where you're caring for more than one person, well, what may work for one person may not work for the other. So your person-centered approach has to be unique for person A and for person B. This is really important because I think oftentimes it can leave us feeling very isolated and alone as the caregiver, because it can be very easy to feel that no one understands what it is that we're going through. Have you ever felt that you're alone in this, that nobody understands what it is that you're going through? Yeah, I see a lot of nodding. Look around the room. You are not alone. Really. And I think that, it probably maybe doesn't need to be said, but it absolutely deserves to be said. Because this disease is so isolating for the person living with it, it's just as isolating for everyone involved in their care. You are not alone. In addition to events such as this, Zicharon has a tremendous resources available for you. The Alzheimer's Association, all of our programs and services are available free of charge. I would encourage you to reach out for assistance. As soon as we realize we cannot do this alone, that we are not alone, we give ourselves a new level of permission to ask for help and accept help. And there are so many reasons why we think we need to do it alone, right? This is my husband, this is my wife, this is my mother, this is my father, this is my sibling, this is my friend, this is my lot in life, this is my role. I would feel guilty if I didn't. There are so many reasons. I probably wouldn't even be able to name them all. No matter what your reason, I don't care who you are. I don't care how much money, how much patience, how much love, how much respect, how much guilt. It doesn't matter. No one can care for somebody with dementia by themselves. You can't do it. It takes too big a toll emotionally, spiritually, financially, physically, any other way that you can name. It is too big. But the beauty is that you don't have to do it alone, right? I think in the last 10, 15, 20 years, the stigma around Alzheimer's and dementia has been reduced to the point where we can ask for help. We can come to a meeting like this and not feel a veil of shame because this is what we're dealing with in our family. And that is the most beautiful thing that I think can happen in this disease in lieu of a cure, because we need to realize that this deserves the attention that it's finally getting. I digress. None of us is born knowing how to care, but it is a skill that we can learn. It's a skill like any other skill, and what that means is it takes time. It means we're going to make mistakes. We are fallible, right? We are human beings. There is no such thing as being the perfect caregiver. If I'm repeating myself, it's intentional. Learning the skill requires a level of acceptance of what it is that we are dealing with. And that's really why I started with some of the facts and a little bit of information about the disease. Because I think at some level, we must begin to accept that this is what we're dealing with. I think that denial is a very comfortable place for a period of time. And often we live in denial until we can't anymore. And I'm here to challenge you to live in denial until you don't let yourself anymore. And obviously you're here, so on some level this acceptance piece has started to already take place. But pulling the curtain back and really looking at the disease and understanding what it is we're up against is the first step to figuring out how to develop the skills to provide the person we're caring for with the kind of care he or she deserves and needs. Implementing this skill requires presence. And what I mean by presence is living in this moment, is taking the time to develop relationship with the person for whom you are caring. And I don't mean relationship, we already have a relationship, this is my dad, this is my wife. That's not what I mean by relationship. By relationship, I mean getting down to eye level, stepping into the world of the person instead of trying to drag the person into our world, and I'm going to talk about that in a little bit in more depth, and really spending time in this moment with the person with the disease and seeing where that goes. Forget the past. Stop worrying about the future. Join the person with the disease where they are right now. Put your BlackBerry down. Put your iPhone away. Let the phone ring, right? Let someone else make dinner. Be in the moment with that individual, in the present, and develop that relationship. Knowing who they are will help you in that. But once you get in there and you connect with the person in that way, in this moment, right here, right now, which is frankly all the person with the disease has, is this moment, this interaction. When we let all that other stuff go and we come at the disease and the interaction through a new lens and from a different perspective, and everything else falls away, we begin to see this relationship develop. And therein lies the person-centered care. It's not easy. I'm the first one to admit that what I'm standing up here saying to you is difficult. And we're going to make mistakes, and that's okay. The person with the disease is doing the best he or she can. That's all that we can ask of ourselves. But the person with the disease cannot change. They cannot be who they were. They cannot engage with us in the way that they have in the past. We need to accept that. Because when we accept that, we realize that if we want the interaction to change, we have to change. And we have the power to change. We do. But we have to learn how to harness that power and how to develop these skills. This is exactly the kind of stuff that we do in the Family Caregiver Workshop, which is a 10-hour training that we have actually brought to Zicharon specifically for the Orthodox Jewish community in Borough Park. Maybe some of you have experienced the workshop. Come, please. It is free of charge. There is a waiting list. I am aware of that. We're offering it as often as we can. But it's roll your sleeves up and let's really talk about how to change the way we're working with the person. So common caregiver issues. There were more pictures here and I realized that some of them disappeared. Whoops. I don't know if you can read these incredibly complex and often overwhelming feelings. What we're talking about is rage, anger, anxiousness, confusion, frustration. Any kind of feeling that you are experiencing is normal. Fear, guilt, resentment, sadness, hopelessness, despair, agony, any kind of feeling that you are experiencing is normal. And I guarantee you, you are not the first person to feel that way, and you will not be the last. Accepting the fact that you're going to have these kinds of feelings is the first step toward moving forward and changing the way you engage with the person. The healthier caregiver becomes an educated caregiver. This is again about pulling the curtain back and looking at what we're dealing with head on, learning as much as we can about the disease, as much as we can about the progression of the disease, so that we understand why the person's doing what they're doing. We're able to put ourselves in the shoes of the individual because we understand, at maybe an arm's length perspective, why they're acting the way they're acting, saying the things they're saying, behaving the way they're behaving. This gives us more patience. It gives us a better sense of what's going on inside the brain so that we can be better caregivers. We will become less angry, less agitated, more caring, more patient, because we're able to put ourselves in the shoes of the person. The healthier caregiver reaches out for help and support. Healthier caregiver accepts changes as they come. That roller coaster, right? You're on the ride. So figure out a way to deal with the coming path of that ride. Again, it's not easy, but what's the alternative? There isn't one, right? The healthier caregiver learns to listen and to hear. And this happens when we're in that moment, when we're in that relationship with the individual, when we've let that other stuff go, when we've carved out an appropriate amount of time where we don't have 5 minutes and we really got to get going, otherwise we're going to be late, and that's not good because the doctor's waiting and the car is far away, and come on, let's get dressed, we have to go. That's not what this is about. This is about if it takes more time, we need to allow for more time. When we are in that moment, engaging with the person on that level, listening and hearing, that's when communication happens, and that's when change can occur. If we don't listen and we can't hear, it will not get any better. If there's one thing I can guarantee you, that is it. If we cannot figure out how to engage with this individual on that one-to-one basis and listen and hear and be present, it's not going to change. I promise you that. You have a doctor's appointment, you have to go to the appointment, what do you do? If it used to take 15 minutes to get ready and get out of the house, you leave an hour. And you start slow, you go slow, you leave more time. And I'm going to get into the concrete stuff in a few minutes. I'm going to go way over. I hope you're comfortable. They let go of being the perfect caregiver we talked about, and we remember that we are not alone, right? So the theory of the two worlds. When I run out of time, I should say, I do not take information out. I just start talking more quickly. So I'm going to expect a lot of you at 9:30 at night. The theory of the two worlds. This is a common aspect of a challenge that people often experience. So often we want to drag the person with the disease into our world. We want to reorient them to what day it is, what week it is, where we are, what they did yesterday, who this person is in this photograph. Do you remember what we had for dinner last night, right? We want to drag them into our world. That's for us. When we want to know if they remember and if they can still and what about, those are things for us. That has nothing to do with the person. I would challenge you, rather than drag the person into our world, step into their world. If they think it's Saturday and it's February and we're in Florida, it makes no difference for you to tell them that it's actually Wednesday and it's October and we're in Brooklyn. It doesn't matter. It matters to you, right? But we need to be able to realize that, recognize that, and understand why. Because if they don't remember and they don't know who that is, then the disease is progressing, right? The person's getting worse. It's worse than I thought it was yesterday. This is all for us. But what matters from a care perspective is that moment right now, this moment right here. So I'm going to step into your world, and if you say it's Saturday and we're in Florida and it's February, I'm going to say I love Florida in February because it's freezing in New York and it's 85 degrees here. And I'm going to see where that goes. Or I might say, what do you love about Florida? Tell me your favorite thing about Florida. But if I cut that off and I say, no, you're wrong. We're not in Florida. We're in New York. Don't you know? We were just outside. We were wherever, right? We were here. And we try to get them into our world. We're missing an opportunity. We are robbing both of us from an opportunity to engage and interact. Instead, we're saying, no, you're wrong. You don't remember. That's not true. Don't you know? Don't you recall? Do you see how we're getting in our own way? Do you see how it's different, how that approach comes at the from a different perspective? That we're presenting an opportunity for engagement in a new way. That's for the person with the disease, not for us. Am I saying forget what you're feeling, forget what you're going through, forget the emotional impact of caring for someone with the disease? Absolutely not. That's what our helpline is for. That's what Zicharon is for. That's what the Family Caregiver Workshop is for. That's what support groups are for. That's what training and education meetings are for. We must deal with the complicated feelings that we're experiencing. But when we are with that person, that is all that matters. Be with the person. Take advantage of every opportunity you have for meaningful engagement and figure out, as difficult as it may be, ways to let that other stuff go. I don't have time for your question right now. I promise I will try to at the end. Communication and Alzheimer's disease. Communication changes occur early in the disease. It may begin in the early stage with word-finding problems. By the middle stage, roughly 1/4 of a person's vocabulary is lost. What that would mean with me is that you didn't understand 1 out of every 4 words I've said so far. You probably would not understand nearly as much as you think you're understanding if 1 out of every 4 words didn't make sense. They don't understand 1 out of every 4 words you're saying, and you probably don't understand a lot of the words that they're saying. By the late stage of the disease, all verbal communication in most instances is lost, so we need to figure out new ways of communicating. Some communication do's. We talked about some of these already. Knowing who the person is. Were they a planner or a doer, an introvert or an extrovert? Did they have a career that you can engage with them? Did they get up every morning and go to work? Or was their career raising a family? That's really important information. That lets you know who this person was. What kinds of things did they enjoy? What kinds of things did they not enjoy? Do they like music? What kinds of music? Do they like certain types of food more than other types of food? All of these kinds of things are tools in your toolbox. So if my grandfather loves music, when he starts to get a little agitated or upset, I need to know what kind of music he responds to. If I put Beyonce on, I'm probably not going to do anything good to calm him down. If I put Benny Goodman on, now we're talking, right? So if the individual likes classical music, you need classical music anywhere you are with this individual in arm's reach. If this person likes chocolate, or if this person likes sweets like lollipops, well, you better have a bag of them with you anytime you're with them. So that if they start to act in a certain way, you can tell that they're starting to get anxious, paranoid, accusatory, upset. You say, hey, look what I found for you. And you give them something they respond to. Does that make sense? Sounds basic, right? We're not born knowing how to do it. We're so caught up in all the other aspects of dealing with the situation we find ourselves in that sometimes the most basic things, the things right in front of us, the duh moments, elude us. Go back to the basics. Who was this person? What got them going? What did they really not like? Whatever that's on that not like list, get it away. Right? It makes sense when we start to think about it at its most basic level. Use familiar words or phrases. Avoid too much information. I'm not going to say, you got to go upstairs and get dressed because we have a doctor's appointment in a half an hour, and after the doctor, I thought we'd go and get something to eat. I wasn't sure which restaurant we would go to. I don't know. I was thinking maybe this place, maybe that place. I guess we'll have to wait and see what the parking is like or if there's traffic on the highway. Okay? What they got was, okay? And you're saying, why are you still standing there? I told you to go get dressed. We got to go, right? Break everything down into manageable tasks, one step at a time. One manageable step at a time. Short, direct messages about what's happening. So that example I gave right now, let's get dressed. That might work in the early stage. As the person progresses toward the middle stage, let's get dressed or go get dressed may be too complicated a task. So what do? We adjust. We break it down into even more manageable tasks, more manageable steps. Let's go pick out our pants. Let's pick out our shirt. We want to use choice, simple choice, in part because it makes your life easier, and in part because it's easier for the person with the disease, and in part because it gives the person with the disease a sense of some control over what's happening to them. The simplest example I could give is around getting dressed. I wouldn't say, what shirt do you want to wear? That may be too complicated for somebody with dementia. I might pick out 2 shirts and say, do you want to wear your red blouse or your blue sweater? So they have control over what's happening to them. You're not telling them what they're going to wear. They can pick which one they want to wear. Even if they don't really care, they just point at one. There's a sense of autonomy that's there, right? And also, it's not so overwhelming. It's something that they can accomplish, giving simple choice. What do you want to eat? Might be too broad. Do you want chicken or fish? Right? Do you want coffee or juice? Simple choices, breaking down tasks. If the person is resistant, they don't want to, ask them if they will help you. Ask them if they'll at least try. Acknowledge what they're giving you emotionally. I know you don't want to. I don't really want to either. What do you say we do it together? It'll be a little bit better. Or, I know you really don't want to do this. I could really use your help. People want to be helpful more than they want to accept help, right? We don't, I'm fine. I'm okay, leave me alone, right? But when we get it, when we have a sense that we're helping someone, there's value added to our lives. We feel good about what we're doing. It's just a slight change in the way that we look at the same situation. Asking the person to help us, asking if they'll just give it a shot. Try, and if it doesn't work, we'll stop. You're setting themselves up for a meaningful engagement, a meaningful outcome. Acknowledge their emotions and reflect back. You seem mad. You seem a little scared right now. Name what they're feeling. Forget focusing just on what they're doing, and that's something that really trips us up a lot. How do I get my dad to stop doing this? How do I get my wife to start doing that? We're focusing on the task and not what's underlying the task. If people are acting in certain ways, we tend to focus on the behavior. I challenge you to put your detective cap on and start digging deeper and exploring what's underneath the behavior. Not, he's banging on the table. Why might he be banging on the table? And we're going to get into that in a little bit. So be prepared to have the same conversation over and over and over and over. If you go in knowing that the person is going to repeat themselves, you are not going to get as annoyed when it happens. Don't just set them up for success, set yourselves up for success. If you knew it used to take 15 minutes to get ready and now it's going to be longer, if you only leave 15 minutes, you're going to get annoyed. Create a win-win situation for you too. Figure out how to allow for the fact that things are different. Go in knowing they're going to be repetitive. Immediately, it takes away some of the power that annoying behavior, and it's annoying, I'm not going to lie to you. It's frustrating. How many times are you going to ask me what time it is, right? We're human beings. We have feelings and emotions. We get annoyed. But if we go in knowing that this is how it's going to be, we set ourselves up for success. We're not going to get as frustrated when it happens. And the last one here, only ask, are you ready to? If you are ready to go away and come back later. Because if I say, are you ready to take a bath? And the person says, no, well, what are you going to do? Too bad, we're taking a bath. Good luck with that one. If I change the way that I ask the question, I set myself up for success. Let's take a bath. Maybe the bath has a lot of grab for that person, the word bath, right? And we've had challenges with this before, so I'm probably giving off some uncomfortable feelings around even bringing the topic up. Maybe instead of saying, let's take a bath, I'll say, let's get cleaned up. And if we do it in the morning, I can frame it as preparing for somewhere where we're going later that day. So let's say we're going to a restaurant or we're going to a temple. Let's get cleaned up. We don't want to be dirty before we go to, right? So that we frame it in a context that makes sense for the person. So it's no longer just a task, and it's no longer just a task that they abhor. It's connected to something that they like, an activity that has meaning, positive meaning for them. Does that make sense? Yeah? Good. Try to figure out what they need or what they want. Anticipate their needs. That's that palliative approach that I was talking about before. Use empathy, not forced reality. You have to mean it. You can't paint on that face of patience, right? So in the example of needing to go, why don't you go upstairs and get dressed? Because if we don't leave in 5 minutes, we're going to be late for the doctor, right? People with dementia are not stupid. They have a disease, right? They are sick. They are absolutely going to pick up on that emotional feeling from you. They're going to know that something's wrong. They may not know why. They're going to absolutely know that something's up, and they're probably going to feel like they did it, that they messed up. They're not thinking the way they used to. Their memory's not what it was. They've been experiencing this. Oh, it's my fault. What you give off, they're going to pick up, and they are probably going to give it right back. Being aware of how we present ourselves is a huge part of success here. Once you think they're listening or responding, then you redirect. Then you distract them onto something else. If it's not working, try and get them up and get them out of that room into a different room. Maybe a change of environment is going to be enough to bring them out of whatever funk they're experiencing in that moment. Use positive, friendly approval. Short, specific, sincere. You've got to mean it. You've got to find a way to be genuine and sincere, or they're going to see right through you. Offer thanks and appreciation. So in the example on the previous slide, if you ask them for help, if you ask them to at least try, you have to thank them. Oh, I really appreciate all that you've done for me. You've made my day so much easier. We all respond to that kind of affirmation. Laugh with the person. Use humor. It is okay to have positive moments. It's okay to laugh. Not at the individual, not at what he or she does, but with the person. Sometimes, even when dementia is around, things are funny, right? It's okay to engage in that way. It will diffuse a tense situation in many ways that other techniques will not. And be careful about personal space and touch. So never walk up to someone and think that it's okay to rub their arm, give them a little massage, rub their back, put lotion on their hands without asking. Even if you have a strong history with this person. Sometimes people don't want to be touched. Sometimes they don't understand the context of your historical relationship, meaning they know that they can trust you, they know that you're someone important to them, but they don't remember who exactly. As the disease progresses, this is common. We cannot assume that it's okay to touch someone. Be careful when we go to touch someone. Make sure that we have permission to do so. If it's not working, you may remember this slide from last year. If whatever you are trying is not working, back off. Stop. I'm sorry. I'm sorry. If you take one thing from tonight, maybe it's I'm sorry. It's incredibly powerful. Literally, I'm sorry. Go away. Come back in 10 minutes with a different tool in your toolbox. If you keep pushing and pushing and pushing, it's never going to work. Do not argue. I said it a lot. Do not order the person around. Do not be condescending or sarcastic. They no longer have the ability to process information in that way. Don't talk about them in front of them, even if you think there's no cognitive activity happening. I promise you, even in the late stage, when it may seem as if they have no cognitive activity happening in their brain, they absolutely do. We never want to talk about somebody with dementia as if they are not there. Don't quiz the person. Remember who those kinds of questions are for. They're for us, and what we really want to spend time focusing on is the person and their needs. This tape just ended. I'm not sure who put it up. You want me to flip it? I'm multitasking. So maximizing communication. We want to set ourselves up for success. We need to pay attention to the time of day. Some people are better in the morning, some are better in the evening. That goes with tasks like bathing, knowing the individual. And we see this oftentimes when people move to assisted living facilities or nursing homes where they try to put everyone on the same schedule. Well, if I like to take showers at night and you're waking me up at 5 in the morning to take a shower, you're darn right I'm going to take a swing at you. You need to know who I am, who I've been for the last 40, 50, 60, 70 years of my life. You come in and you try to change that, who's going to be accepting to that kind of change? What if I like to take baths and I hated showers for whatever reason? You're trying to get me in the shower. It's not going to work. The only way to successful intervention is to know who it is you're caring for. Behavior equals communication. And I've touched on this. When people are behaving in a certain way, they are attempting to communicate an unmet need. When people are banging on a table, throwing things, screaming, yelling, kicking, spitting, biting, they are trying to tell you something. And this is what I was talking about when I said, put the detective cap on, stop thinking about just what they're doing, and figure out why they're doing what they're doing. When we talk about behavioral challenges, you can generally put them all into these 5 categories: physical, emotional, environmental, task-related, and communication. The communication we spend a lot of time on. Physical, are they in pain? Right? Do they have other health issues that need to be addressed? Is their shoe on too tight? Is their belt on too tight? Did they stub their toe? Emotional, are they scared? Are they anxious? Are they depressed? Environmental, are the lights too bright? Is there too much stimulation? Dr. Kennedy talked about overstimulation, understimulation. Everybody needs a different level, and sometimes the same person will need a variety of levels in one day, perhaps. We need to understand what's causing the behavior. If there's a lot of talking going on the side, and the TV's on, and the radio's on in the other room, and the kids are fighting downstairs, and I'm trying to have an engaging moment with this person, it's probably not going to go as well as it would if I were to get rid of all of the distractions, right? So we need to be paying attention. Is it too hot? Is it too cold? Is it too bright? And is the sun in their eyes, right? All these kinds of things we need to think they're acting in a certain way because of something. And if we figure out why, then we can figure out what to do about it. But if we only focus on the behavior, it's never going to end. Because how do I get you to stop banging if I don't know why you're banging? I could get you to stop banging by holding down your hands and saying, stop doing that, you're driving me nuts. As soon as I let go, you're probably going to start banging again, right? But if I figure out it's because you're in pain, and I treat your pain, the banging goes away. Anyone hear of sundowning? It's around 4 or 5 o'clock, typically when the sun goes down. I think that's why it got that name. When people start to behave differently, their behavior starts to change, right? One nursing home in Arizona found that if they provided, excuse me, people with dementia an opportunity to rest during the day when they became clearly tired, that their sundowning went away completely. So often we think, I can't let you take a nap because then you're going to be up all night, right? Think how exhausting it must be to have dementia and be trying to make sense of every little thing around you 24 hours a day. Think how exhausting it must be. Put yourself in the shoes, as difficult as it is, of the person with the disease, and try and understand that they are trying to make sense out of where they are and who that is and what's happening around them, and is this where they're supposed to be, and is that what's supposed to be happening right now, and I feel like I'm forgetting something, and there's something I'm supposed to be doing, and where's that thing that I knew was important that I put somewhere? It is exhausting. And then we're coming at them with, please go upstairs and get dressed, because if we don't leave within 5 minutes, we're going to, right? We set ourselves up for failure because we've let ourselves forget what's going on with the person. We have to figure out a way to step into their world, right? Does that make sense? Is it resonating with you? Okay. So who the person is, I talked a lot about this already. These are just some of the other kinds of questions you can start to explore. Their favorite topics, their favorite music, places, typical behaviors under stress, so that you can get a sense of how they historically have responded to stress, so that you know when they're in a stressful situation. Their personal care habits, if they shower or bathe in the morning or at night. Their work history, their leisure background, their religious or spiritual beliefs, their hot buttons and stressors, all these things become tools in your toolboxes. What the person is doing versus why, we've talked a lot about that. Your responses need to be person-centered and make the brain a better offer. What I mean by this is the example that I gave of how exhausted how exhausting it must be for that person to be trying to make sense of everything that's happening around them. They're behaving in a certain way because this is what the disease has done to their brain. But if you can engage with them in a different way and make their brain a better offer, and by that I mean engaging with them in an activity that you know brings them pleasure, whether it's modified for where they are in the stage of the disease so that they can do it and feel success and have it bring value to their life, that's making the brain a better offer. When you offer them an opportunity to engage in a way that sets themselves up for success, that speaks to their dignity as a human being, and not someone who can't do things anymore, but someone who still has value and still adds value to life, to the world, to the family, then we change things. Then we start to change the way that encounters go. And we start to bring out new opportunities for engagement in a successful way. So remember, if you've met one person with dementia, you've met one person with dementia. Dementia knows no bounds. We're all at risk. And I put that up there really not to make everyone feel sad, especially at the end of my very long talk. I apologize for going way over. But I put that up there so that we realize that oftentimes we feel he was so smart. She was so productive. He was a scientist. She was a doctor. She raised this incredible family. He, was such a leader in the community. And we get stuck in how awful it is that the person is experiencing losses. But when we think about the fact that dementia is universal, it doesn't matter your religion, it doesn't matter your race, it doesn't matter your gender, your ethnicity, your wealth, your social status, it knows no bounds. That helps kind of, I think, reframe our expectations and our sense of the situations in which we find ourselves. And it helps, I think, reinforce what I started with, which is we are not alone in this. And there are ways to make it better. There is no magic bullet. And as soon as we realize and accept that, then we open ourselves up to all of these other possible interventions. The person with dementia is doing the best he or she can. No one is doing this on purpose. And I think that's a big one for us too, especially when we're caring for a parent, I'm sorry to say. She always did this to get me to feel this way, or he was always like that when he didn't like what I did or said. They're not doing it on purpose. They are not doing it to manipulate us. They're not trying to get under our skin. They're doing the best they can. As the disease progresses, the person will need more and more care. So we need to start to anticipate what those needs might be. Oftentimes people say, I can't look down the road. I can't deal with what's coming 6 months from now or a year from now. I can only focus on what's right here in front of me. I challenge you that the only way to successfully deal with this entire spectrum of a disease is to allow yourself to become as educated about what the future will bring as possible. Because if we just let it come, we're going to have that rug pulled out from under us countless times, over and over and over. And as that rug's pulled out, you're going to fall down, you're going to bang your head, you're going to hit your elbow. We have to figure out a way to be able to continue to stand, despite what's coming at us. You're on that roller coaster, hang on. Figure out how to ride that ride. That's the only way to survive this. Whatever you're feeling is normal. You can't do it alone. I said that a lot. Our programs and services, I'm going to skip over. I did bring a brochure. It's out on the table in front where you signed in. It really lays out in pretty in depth what we do, who we are, how we do it. Everything is available free of charge. There is no reason why you should not be taking advantage of our programs and services. I thank you so much for your time. I know you probably have lots of questions. I lied and I didn't mean to when I said that we would have time. I go on. I hope that you found tonight valuable. I can stay for a couple of minutes, but I do have to leave by 10 o'clock. But I will say that we have a 24-hour helpline available. We have done cultural competency training with Zicharon, with Harriet Blank, who's here from OHEL. My staff has been trained in some of the unique issues that the Orthodox community is facing. Do not feel that we cannot help you. Please let us help you. If there are things we don't know, we will learn with you so that we can meet your needs in a meaningful way. Thank you. Thank you so much. I answered a lot of your questions. Thank you. I appreciate that. I don't feel as bad.